Dr. Patrick Serruys, and he'll talk about Everolimus-eluting bioresorbable vascular scaffolds versus durable polymer Everolimus-eluting metallic stents in patients with acute myocardial infarctions, the results of the ABSORB STEMI TROFI II trial.
Thank you, Chairman, for introducing the title. It's on behalf of these two PI, Manel Sabate and Stefan Windecker, that I'm presenting these data. This is the disclosure statement of financial interest. It is a study which is sponsored by the European Cardiovascular Research Institute, ECRI, and we are the grant giver are Abbott and Terumo, but they are not involved in the conduct of the trial. So the background is there is no head-to-head comparison to assess the early phase of the arterial healing response to a bioresorbable scaffold, ABSORB implantation in patients with STEMI relative to the healing of the metallic drug-eluting stent. And we want to compare the arterial healing response of these two technologies by optical frequency domain imaging, or FDI, or OCT. We develop a score, an healing score. As you could see, intraluminal defect has a 4-point score, a malapose and uncover struts a 3-point score, uncover opposed 2 point, and malapose cover 1 point. It's allow us to assess the healing. So technology, drug struts coverage is very important. You see a metallic drug-eluting stent and bioresorbable. These days we have developed light intensity analysis to detect the amount of coverage that we have on top of the struts. It's very useful to make the analysis objective and reproducible. This is a typical example of a patient acute myocardial infarction who will receive science, has a healing score of 12.2. As you could see, not only we look specifically to the malapose and uncover, but we have a 3D representation, color-coded the intimal thickening going up to 300 micron, but then you see the apose uncovered struts in orange, and in this case, the malapose covered in purple color. Study design, randomized 1-to-1, non-inferiority trial, 191 patients, randomization performed after establishment of at least a TIMI2 flow after thrombus aspiration and DAPT for 1 year. It's a non-inferiority design where we use the healing score of the previous cohort of patients treated with the ABSORB. They were nevertheless stable patients. As you could see, the healing score in that population was 9. We used non-inferiority margin of 4.5, and then we were power with a population of 190 patients. I will not describe the criteria of STEMI. Note that the exclusion implied tortuosity and calcification of the vessel so that we could do the OCT, which is a quite fragile catheters. Here's the flow chart. We have the randomization. Then we have some sizing based on angiography. We were allowed to do a post-dilatation and thrombectomy after implantation of the scaffold device of the stenting. And as you could see, 86 patients out of the 95 came back for the angio and the OFDI in the ABSORB group and 87 in the stent group. Nothing special about the baseline characteristic, which are well balanced in both groups. Majority of patients are in class KLIP 1. The global time onset to symptoms thrombectomy pre-dilatation was 177 minutes in one group and 185 in the other group, no difference. Majority of RCA followed by LAD and circumflex. 60% of more than 60% as a TIMI 0, 25% and 20% as a TIMI 3. You see the treatment in terms of aspirin and the different antiplatelet agent, with the majority receiving ticagrelor followed by clopidogrel and prasugrel. I will not describe the medication during procedure. So what is important in the procedural aspect is that the nominal size of the ABSORB was significantly and slightly larger than the metallic device. There were more pulse dilatation in the ABSORB. Nevertheless, the pressure in the metal stent was higher. Now we come to some first good news. In contrast to the ABSORB II, this time we have almost equal acute gain in both groups, and we end up post-procedure in this acute myocardial infarction with the same MLD 2.46, so both perform very well equally in this setting. This is an example of ABSORB with a healing score of 0, which is good. As you could look, you can judge by yourself, all the struts are opposed and well covered. And this is reflected also in the 3D analysis. There is no purple, no red, some dark blue here for a region with 300 micron of neointima. This is the primary endpoint, non-inferiority, which was met. It's the cumulative frequency curve of the healing score. What means is that 40% of the patient has an healing score of 0, perfect healing. Then you see the curve start to diverge, which allow to use the p-value for non-inferiority, P001, we almost reach a p-value for superiority. In terms of OCT at follow-up, we are pleased to see that for every parameters there was equal, so the two devices from a mechanical point of view at 6 months provide the same times of flow and lumen area. Nevertheless, there was a little bit more and significantly more neointimal area for the ABSORB, 1.52 versus 1.35, and the neointimal thickness on top of the struts was 110 micron versus 90 micron, highly significant, but we like this difference and this nice coverage of the lesion. At follow-up, there was some significant difference in device diameter stenosis, but it's just less than 3-4 points. The loss was excellent, 0.20. It was also excellent in the metallic stent, 0.8 millimeter, and there was one binary stenosis in each group. Clinical follow-up, it's a highly selected population, so there were basically 1.1% of event in the ABSORB and 0% in the science. There's only one patient suffering a subacute definite scaffold thrombose leading to MI and clinically driven TLR in the ABSORB group. This was a patient where the device was implanted in a too small vessel, inadequate according to the protocol. Angina-free equally in these two groups, 91%. So in conclusion, the scaffolding of culprit lesion with this bioresorbable scaffold in the setting of STEMI result in nearly complete arterial healing, which was comparable to that of metallic drug-eluting stent at 6 months. The frequency of malapose and both malapose and uncovered struts were lower in the ABSORB arm, while there was no presence of intraluminal mass in both groups. Quantitative coronary angiography revealed similar acute gain and MLD procedure at 6 months. Late lumen loss was lower in the metallic drug-eluting stent, but binary restenosis rate was comparable, low between the two groups. I should emphasize that these findings cannot be extrapolated to other bioresorbable devices with different material of strut thickness. Thank you very much.
Questions for Dr. Serruys?
Yeah, thanks. Bruce Jansen with Cardiology News. So over what time period is the Everolimus dispensed from the strut?
Sorry, I didn't catch the question. How
It's the time period over which everolimus
Okay.
is eluted from the stent.
Yes, it's about 30 days in both cases, yeah.
And is the idea that ultimately this bioabsorbable stent might be able to be managed using the same short dual antiplatelet regimen as with a bare metal stent?
That's something which still has to be explored. The key point is that when you put a metallic cage in a vessel with thrombus and vasoconstriction because you are in the phase of myocardial infarction, the thrombus will dissolve, the vessel will relax, but the metallic cage will stay where it was initially implanted under certain pressure and with a certain balloon. In the case of the biodegradable, you will have the same phenomenon, but at the very end, the polymeric structure will disappear and will not let these uncaged metallic struts more or less oppose and more or less cover. That's the initial concept. Now, in terms of dual antiplatelet therapy, the field is, I would say, virgin. I mean, we have no trial testing so far the duration of one regimen versus another.
And does the dissolved polymer go downstream?
No, it's a very good question of you. I mean, there are on these bioresorbable scaffold two tiny pieces of metal that you can follow very well on multi-slide CT scan. So it was the great test to see if these tiny markers were not opposed at the time of the implantation, what was their outcome. And it turns out that with multi-slide CT scan, months and years after, the two radiopaque markers were still at the same site in the vessel at the site of implantation, which is, I think, one of the best demonstrations that there is a very slow and progressive integration of the material in the vessel wall without embolizing anything downstream.
So, one more short question, short answer, please.
Hi, I'm Dawn Powell from Cardiovascular News. I know that, Dr. Serruys, you're on record for saying that you think bioresorbable scaffolds are the future for PCI. And I was just wondering whether you think it's the current generation of bioresorbable scaffolds like ABSORB that are going to be the ones that become gold standard, or do you think these show promise, but it's going to be actually next generation of devices that will be the one that become the gold standard?
Very good question. I've been there for a long time, so I've always seen the first generation, the second, the third, and so on. So I think that correctly, as you said, we are dealing with the first generation who have some deficiency and things that we would like to improve. The first one is the thickness of the struts, which is quite large, 150 micron, which make for the interventional cardiologist the procedure somewhat more difficult because it's a bulky device. But on the other hand, I would like to let you know that there is 27 companies around working on it, and it is no day that I don't see some improvement in the technology. So I really believe that within 5 years, a great deal of the metallic will be reduced. I made that guess that metal will be minority in 2020.
Okay, thank you. So I think that's a very good point to move on.